The three main recognized types of clinically distinct disease caused by protozoa of the genus Leishmania are cutaneous leishmaniasis, mucocutaneous leishmaniasis, and visceral leishmaniasis, also known as Kala-Azar. A clinical condition, diffuse cutaneous leishmaniasis, exists in East Africa and South America. Its exact position in the leishmaniasis spectrum is not yet decided. Our attention is devoted exclusively to cutaneous leishmaniasis. Cutaneous leishmaniasis is an infectious granuloma of the skin. It begins with a papule which may develop central necrosis. The lesion generally extends into an indolent ulcer which crusts over. Ultimately, it heals, leaving a scar. The disease is caused by Leishmania tropica, a parasite of the skin which is transmitted from host to host by a vector fly. The lesions may be single or multiple, depending on the number of infective bites. Cutaneous leishmaniasis is widely distributed. It is found in the Mediterranean region, extending throughout the Middle East into Turkestan and northern India. In India, it is prevalent mainly in the plains of the Ganges and Hindu rivers. Cases are also found in the southern reaches of the Soviet Union, other parts of Central Asia, South America, and East and West Africa. Wet urban and dry rural types of the disease have been described. The disease, commonly called Oriental sore, is also known as Jericho boil, Bouton de Baghdad, Aleppo evil, Bouton de Biskra, Delhi boil, as Salek in Iran, and Penda sore in the Soviet Union. The vicinity of the city of Jericho in the Jordan Valley is one of the foci of the disease. The local vector is the sandfly Phlebotomus papatazi. Netting designed to prevent the passage of mosquitoes will not hold back the smaller sandfly. During the day, sandflies hide from the sun in relatively cool and humid places. Such as cracks in walls, corners of buildings, and also rodent burrows. The local reservoir host of Leishmania tropica is Samomys obesus, a rodent which lives in the dry and sparsely vegetated sand. The burrows of Samomys are invariably located in the immediate vicinity of the saltbush Atriplex halamus, a shrub which constitutes their staple diet. 40% of these rodents, trapped in the Jericho area, were found to harbor Leishmania. Elsewhere, other animals are the proved or suspected reservoir hosts. For generations, the disease has been endemic in the Jericho area. With the advent of insecticides, which were used in inhabited areas primarily for malaria control, Phlebotomus papatazi was amongst the first insects to disappear. With recent settlement of previously uninhabited areas in the Jordan Valley, Oriental sore has reappeared. When a phlebotomist feeds on an infected animal, it ingests macrophages containing the aflagellate intracellular form of the parasite, the amastigote, also known as the Leishman-Donovan or LD body. The amastigote grows a flagellum, thus transforming into a promastigote or leptomonad. Forward migration of flagellates begins in the midgut of the sandfly after approximately 5 days. They eventually accumulate near the mouthparts of the phlebotomous. After about 10 days, the sandfly is infected. Flagellates may enter the human body via the bite and multiply intracellularly as amastigotes in the dermal histiocytes of infected areas, completing the biological cycle. An indurated nodule usually appears several weeks following an infective bite. The initial nodule gradually enlarges and frequently ulcerates. This process may take some months. Regional lymph nodes do not become enlarged unless secondary bacterial infection occurs. Multiple lesions may occur from multiple bites, or when the infection is mechanically spread by scratching. Hematogenic spread is extremely rare. The histological picture of cutaneous leishmaniasis is that of a dermal infiltrate consisting of several types of cell. In time, histiocytes predominate. In the early stages, many LD bodies are seen in the cytoplasm of the histiocytes. These may at times be so numerous as to give a salt and pepper appearance. In later stages, LD bodies become progressively scarcer. It is necessary to differentiate nodular ulcerative leishmaniasis from insect bites, furuncle, syphilitic ulcers, malignant ulcer, and other conditions.
Self-healing nodular ulcerative cutaneous leishmaniasis is the most common form of disease induced by Leishmania tropica. A defective immune mechanism to oriental sore is thought to deny certain people the ability to achieve radical cure. Leishmaniasis recidivans results. In this form, healing is only partial. Lesions tend to spread centrifugally, and active nodules may remain present in the central atrophic regions. The condition may relapse after apparent cure. Subsequent scarring can be extensive and cosmetic disfigurement more serious than in the nodular ulcerative type. This lesion exhibits a tuberculoid granulomatous structure with giant cells, epithelioid cells, and lymphocytes. Amastigotes, LD bodies, are rarely seen, but their presence can be demonstrated by culturing of biopsy material. Leishmaniasis recidivans most frequently resembles lupus vulgaris. It may sometimes be confused with chronic discoid lupus erythematosus and rosacea.
It may also resemble fungal infection and psoriasis.
Diascopy of lesions of the recidivans type will reveal a characteristic apple jelly texture similar to that found in lupus vulgaris.
Diagnosis of cutaneous leishmaniasis is established by demonstrating the parasite microscopically or by culture. A drop of tissue juice from the incision is aspirated from the periphery of the lesion, as the ulcerating center is likely to be contaminated with bacteria. The tissue juice is spread on a slide and stained. In the early stages of the nodular ulcerative form, parasites are relatively abundant. As the lesion heals, amastigotes gradually diminish in number. Cultures are grown in a medium containing blood or serum. They are maintained at temperatures optimal for the parasite. Promastigotes will develop and multiply within a few hours at 23 to 28 degrees centigrade. An aid to the diagnosis of cutaneous leishmaniasis is the Leishmanin or Montenegro test. Cured Leishmania flagellates in phenol solution are injected intradermally. The test reveals delayed hypersensitivity similar to the tuberculin test and is read at 48 hours. A positive result indicates either past or current infection. Any of the three main species of Leishmania may serve as antigen, indicating that they share a common factor. Persons of all ages and both sexes are equally susceptible to cutaneous leishmaniasis. People who have recovered from the disease are immune to reinfection. For many years, Israeli scientists have been involved in the collection and serological characterization of Leishmania strains. Many fundamental studies in Leishmania were carried out by Adler, Theodore, and Ostrovsky. The World Health Organization's International Reference Center for Leishmaniasis is maintained at the Department of Protozoology of the Hebrew University Hadassah Medical School. The department has recently developed a gel diffusion test for grouping Leishmania strains into distinct serotypes based on excreted metabolites. The first strain was deposited in the collection in 1927 and is still producing an excreted factor indistinguishable from that of a newly isolated strain from the same geographic region. Leishmania strains are collected from all endemic areas. These are available on request to research workers throughout the world. Transmission of the disease can be interrupted in three ways: measures against the reservoir host, control of the vector, and protection of the human host. Measures against the reservoir host and vector include the destruction of their ecological niche. In the Jordan Valley, the elimination of the atriplex shrub in the vicinity of human dwellings deprives the local rodent of its staple diet, forcing it to migrate to places farther removed. Since the flight range of the phlebotomous is usually not more than several hundred yards, this measure tends to reduce contact between infected sandflies and human beings. Spraying of insecticides in and around dwellings reduces sandfly population. Among methods to protect the human host are the use of insect repellents and the covering of exposed areas of the body. Since solid immunity follows recovery from the infection, a controlled inoculation is desirable for persons about to enter endemic areas for extended stays. Inoculation should be carried out several months before expected exposure in order to allow immunity to develop. Viable strains of Leishmania tropica are used for this purpose. A nodular ulcerative lesion usually heals spontaneously within 12 months. Small lesions which have not ulcerated may heal sooner and only leave minimal scarring. Large ulcerated lesions may take 18 months to heal, leaving a scar frequently depressed, pitted, and sometimes pigmented. When the lesion is small and inconspicuous, it is probably wiser to refrain from active treatment, allowing immunity to develop. If, however, the lesion is rapidly enlarging and disfigurement becomes imminent, early treatment should be given.
Chemical methods of treatment which reduce the viability of the parasite include the intramuscular or intralesional injection of antimonials or intralesional mepocrine. Physical methods include freezing with carbon dioxide snow. Good results have been achieved by irradiation with Grentz rays. Among other physical methods which arrest the process are cauterization and electrocoagulation. In Leishmaniasis recidivans, cases are frequently resistant to all modes of treatment. But intramuscular antimony combined with intralesional corticosteroids is sometimes effective. In this patient, intravenous infusions of amphotericin B have produced marked clinical improvement.
Plastic surgery may be considered after complete healing to remove scar tissue, but is contraindicated when the disease is still active. In endemic areas where the disease is well known, the main problem of cutaneous leishmaniasis is prevention. Ideally, the local animal reservoir and insect vector should be eradicated.
Insect repellents and protective clothing are of some value. For those expected to have a high risk of exposure, consideration should be given to the deliberate inoculation of cultured organisms into a covered and inconspicuous site.
Popular travel and rapid transportation have led to the appearance of leishmaniasis in non-endemic areas. Here, the index of suspicion for the disease is low, and the chief problem is diagnosis. Any chronic inflammatory papule, nodule, plaque, or infiltrated ulcer of the skin could be cutaneous leishmaniasis. If this diagnosis cannot be eliminated on the basis of the history and clinical features, cultures, histological and immunological examinations should be made.